Okay, today our topic is sepsis and septic shock. Hi, my name is Tanali, and I'm going to be talking about pathophysiology and clinical manifestations. Let's begin with patho. Sepsis is a systemic inflammatory response to an infection. Severe sepsis, sepsis complicated by organ dysfunction. Septic shock, presence of sepsis with hypotension despite adequate fluid resuscitation, along with adequate tissue perfusion resulting in tissue hypoxia. This can be caused by bacteria, parasites, fungi, and viruses. The body's response is an increased inflammation, coagulation, and decreased fibrinolysis, increased microthrombi, and obstruction of microvasculature, causing damage to the endothelium. Here we have a diagram showing the differences between sepsis and septic shock. Sepsis is a life-threatening condition that arises when the body's response to infection injures its own tissues and organs. Septic shock. Septic shock is a subset of sepsis, which is associated with a significant rate of mortality as a result of various fatal abnormalities of blood circulation and cellular metabolism, also known as the last stage of sepsis. Okay, so I don't know about you guys, but I'm a visual learner, so here's another diagram. This one's talking about sepsis steps. SIRS is a systemic inflammatory response syndrome, and the characteristics for that is greater than 100.4 temperature or less than 96.8. Respiratory rate greater than 20, heart rate greater than 90, white blood count greater than 12,000, less than 4,000, or greater by 10%. And the PCO2 greater than 32. Sepsis is 2 SIRS plus confirmed or suspected infection. Severe sepsis is sepsis plus signs of end of organ damage, hypotension, a systolic blood pressure less than 90, and a lactate lab greater than 4. Septic shock is severe sepsis with persistent signs of end of organ damage, hypotension, systolic blood pressure less than 90, and a lactate greater than 4. The three major effects: vasodilation, maldistribution of blood flow, and myocardial depression. In the image to the right, step 3 shows vasodilation in effect and how it can affect the organs and ultimately lead to death. Causes of sepsis can be infection, pneumonia, peritonitis, a urinary tract infection, invasive procedures, indwelling lines, and catheters. Patients at risk are older adults, chronic diseased, immunosuppressed, malnourished, and debilitated. Okay, on to clinical manifestations. Cardiovascular system is affected by decreased temperature, myocardial dysfunction, biventricular dilation, and decreased ejection fractures. The pulmonary system: hyperventilation, crackles, respiratory alkalosis, hypoxemia, respiratory failure, acute respiratory distress syndrome, and pulmonary hypertension. Respiratory failure happens in 85% of patients, and they may require intubation and mechanical ventilation. In the renal system, it causes a decreased urine output.
Hi everybody, this is Isabel. Today I'll be discussing the risk factors associated with sepsis. These risk factors include age, such as children younger than 1 year old, or older adults 65 years or older, having a compromised immune system, such as those individuals with chronic illnesses such as diabetes, kidney disease, lung disease, or liver disease. Also, hospitalized patients, especially those in the ICU settings, are a higher risk. Clients with traumatic or non-traumatic wounds, such as fractures, surgical wounds, pressure ulcers, and burns, are very susceptible to become septic. Other risk factors include invasive diagnostic procedures such as cardiac cath, colonoscopy, and biopsies. The use of invasive devices such as IV catheters, central lines, PICC lines, and Foley catheters. Also the use of intravenous illicit drugs such as heroin. These drug users are high risk to develop abscesses at the injection site, and this infection can turn into sepsis. For lab and diagnostic tests, there is not one single lab or test that can be ordered to diagnose sepsis, but rather, doctors will order these tests or labs depending on the clinical manifestation of the client presenting with sepsis. But there are some common ones that we see order, and these are cultures, such as in blood cultures, sputum cultures, urine cultures. Another test is the urinalysis, and this is to test for the presence of UTI. Another test is a CVC with differential, and there are two important markers in the CVC with differentials, and these are increase in white blood count, which indicates infection, and also a decrease in platelet count. Now, another test that is very important is the lactate level, and the lactate is a marker for tissue hypoxia. Increased level of lactate in the blood indicates that there is not enough perfusion in the body, and that there's also a lack of oxygen being delivered to the body's tissue. Another test order is an EKG, and this is a 12-lead EKG, and this is to assess for any cardiac abnormalities. X-rays, such as chest X-ray and abdominal X-ray, are also ordered. Glucose testing, this is very important, especially for the critically ill patient, and this is due to stress hyperglycemia. These patients can develop hypoglycemia, and doctors will do a very tight glycemic control on these patients. Another test that are usually ordered are the D-dimers, the C-reactive proteins, PT and PTT, and this is because clients with sepsis are high risk for clot formations and also for bleeding, and this is due to the decrease in platelet count and also the clumping of the platelets. And then the CT scan. CT scans are not usually ordered as a routine testing, but sometimes when the X-ray won't show any infection and they need to find more information or check more in depth about abscesses or other infections, they will perform what the doctors will order a CT scan.
This is Abby Dickey, and I will be discussing the pharmacological interventions of septic shock. Our initial interventions for our sepsis patients are going to include adequate oxygen delivery, fluid resuscitation, and broad-spectrum antibiotics. These are going to be the most important for our sepsis patients. If our oxygen delivery, our fluid resuscitation, and our broad-spectrum antibiotics are unsuccessful, we're going to move on to vasopressors and steroids to try to increase the blood pressure from their hypotensive state. Okay, let's talk about fluid resuscitation. There are a couple different types of IV fluids that we can use. Let's first talk about isotonic crystalloids. Normal saline and lactated ringers can be used. Typically, normal saline is used. These solutions expand the intravascular and interstitial fluid spaces. Large quantities are required to maintain adequate circulating volume. I will note that lactated ringers should be used cautiously in all shock situations because the failing liver cannot convert lactate into bicarb, causing serum lactate levels to increase. Another type of IV fluid that can be used is colloid fluids, such as albumin. These provide oncotic expansion of the plasma volume. They expand the plasma volume to a greater degree than isotonic crystalloids. They also reduce the tendency towards pulmonary and cerebral edema. Studies have been done to determine which solution achieves the greatest results. SurvivingSepsis.org states that albumin might have some, albeit not statistically significant, benefit in patients with severe sepsis. It is up to the doctors to decide which type of IV fluid would best treat the individual patient. No matter which type of IV fluid is used for fluid resuscitation, the goal remains the same: to restore the intravascular volume and increase tissue perfusion. The endpoints for fluid resuscitation are a CVP of 8 to 12, a mean arterial pressure greater than 65, a urine output greater than 0.5 milliliters per kilogram per hour, or a normalized lactate level, and a normal lactate level is less than 2.3. Alright, here's what you need to know about isotonic fluid resuscitation. You want to be monitoring their central venous pressure and their central venous O2 saturation. Like I said before, the goal is a CVP of 8 to 12, and your goal for central venous oxygen saturation is greater than 70%. You're going to be administering these fluids at 30 to 50 milliliters per kilogram. This means that a 150-pound patient is going to be receiving approximately 2,045 milliliters of fluid. This is a lot of fluid, and it should be given over approximately 3 hours or as much as a patient can tolerate. According to my research, it is initiated within the 3-hour bundle phase. An initial bolus is given and then continuous infusion. Patients should be carefully monitored and observed for evidence of pulmonary and systemic edema. They're receiving a lot of fluid in a short amount of time. Signs and symptoms of pulmonary edema include wheezing, trouble breathing, chest discomfort, or coughing up peak frothy sputum. And then signs and symptoms for systemic edema are going to be swelling within the extremities, pitting edema. So we want to monitor that while giving these fluids. After fluid resuscitation has been initiated, you want to start antibiotics. You're going to be either using a broad-spectrum antibiotic or multiple antibiotics at one time. These antibiotics need to be started within 1 hour of septic shock. You want to obtain blood cultures before starting antibiotic therapy. However, if for some reason blood cultures cannot be obtained, do not delay antibiotic administration. It is very important to inhibit the infection and inflammatory response. Some antibiotics that are used are Zosyn, Flagyl, Rocephin, and Cipro, but it's up to the doctor's discretion as to which pharmacological intervention will be used. For hypotension that does not respond to the initial fluid resuscitation, you're going to next use vasopressors. They're used to elevate the blood pressure, induce vasoconstriction, and elevate the MAP. They're used as a second-line agent in the treatment of shock. If hypotension persists after fluid administration for septic shock, give vasopressors to maintain a goal pressure, mean arterial pressure of 65. You're going to monitor your urine output and LOC and serum lactate levels to ensure that tissue perfusion is adequate. Sometimes fluid resuscitation alone may suffice. When appropriate fluid resuscitation fails to restore an adequate arterial pressure and organ perfusion, therapy with a vasopressor agent should be started. Your first choice of vasopressors in response to septic shock will be norepinephrine or Levophed. It is the first choice to correct hypotension. Epinephrine, adrenaline may also be used as an additional agent if it is needed to maintain adequate blood pressure. Other vasopressors include dopamine, which is a systemic vasodilation, and vasopressin. Vasopressin has vasopressive and antidiuretic hormone activity. It may be given if non-responsive to other vasopressors. You want to infuse this at low doses. Do not titrate infusion, and you also want to caution giving this to cardiac patients. There are a couple things that you want to monitor while administering vasopressors. Vasopressors can cause peripheral vasoconstriction and an increase in systemic vascular resistance, further risking tissue perfusion. Vasopressors may raise BP at the expense of the perfusion of vulnerable organs, such as the kidneys. You want to weigh the risk versus the benefits when using vasopressors. After you have administered oxygen, you've given fluid resuscitation, and you have hung antibiotics, and you've also given vasopressors, and you have still not raised the blood pressure of your patient, corticosteroids may be considered. They decrease inflammation, increase heart rate, and blood pressure. They may be used in a select group of patients who have responded poorly to the fluid resuscitation and vasopressive therapy. It's an anti-inflammatory agent to help maintain vascular tone in states of shock. The use of corticosteroids in septic stocks still remains controversial. There is no consistent proof of increased survival outcomes that have been seen in clinical trials. The drug of choice is Solu-Cortef, and when you give this drug, you want to make sure you monitor for hypokalemia and hyperglycemia. Other pharmacological interventions that are not as crucial as the others discussed, but are still important, are your glucose levels and the prevention of stress ulcers. Glucose levels should be maintained under 180, so you want to frequently monitor and treat high blood sugars. In addition to that, you want to treat stress ulcers with prevention with PPIs, such as Protonix.
Sepsis, collaborative care and teaching. My name is Kiosha, and I will be talking about sepsis, collaborative care and teaching. My name is Kiosha, and today I will be talking about collaborative care and teaching of sepsis. Collaborative care. Collaborative care. Patients in sepsis shock require a large amount of fluid replacement. Use of fluid challenge technique is repeated until hemodynamic improvement is noted. To optimize and evaluate large fluid volume resuscitation, hemodynamic monitoring with a minimum of a central venous catheter is needed. The primary goal of fluid resuscitation is to restore the intravascular volume and organ perfusion. Teaching. Know your medications, what they look like, how much you should take each time, how often you should take them, and why you are taking them. Take medications exactly how the doctor tells you to. Even when symptoms are gone, it is important to finish all antibiotics. Keep follow-up appointments and routine testing. Follow treatment plans provided by the doctor. Get plenty of rest and eat a well-balanced diet and stay hydrated. Steps you can take to prevent infections leading to sepsis are: take care of chronic conditions, prevent infections, get recommended vaccines, know the symptoms of sepsis. Steps you can take to prevent infections leading to sepsis are: take care of chronic conditions, prevent infections, get and recommended vaccines, and know symptoms of sepsis. Practice good hygiene. Perform good hand washing technique. Keep wounds clean until healed. Most important, get medical care immediately when an infection does not get better or gets worse.